Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Sage Therapeutics and Biogen, Inc.
Hello, I'm Dr. Jody Glantz, Associate Professor of Psychiatry at the University of Pittsburgh School of Medicine in Pittsburgh, Pennsylvania. Welcome to this program titled Empowering Mothers, Early Identification and Treatment of Postpartum Depression. By the end of this program, you will be better equipped to identify some key clinical features of postpartum depression for more rapid diagnosis, understand the clinical guidelines for screening and diagnosing postpartum depression, and have a better understanding of what treatments are available. So let's start with some epidemiology. What does your experience tell you about the prevalence of postpartum depression in the United States? It's estimated that 1 in 8 postpartum patients in the United States may be having and suffering from postpartum depression. So that's approximately 450,000 women every year. So when we talk about postpartum depression, it's important to first differentiate postpartum depression from baby blues or postpartum blues, and then look at the risk factors for developing these disorders. So baby blues, also known as postpartum blues, is not the same as postpartum depression. These are more mild and transient symptoms, such as mood lability, irritability, sometimes tearfulness, sometimes accompanied by anxiety. And this really starts quickly. It peaks in the first 5 days postpartum, and then it typically resolves within the first 2 weeks. This does not significantly impair the person's functioning, and it's very common, probably around 70%. This is different from postpartum depression. So postpartum depression is also considered a major depressive episode with a peripartum onset specifier, as in the DSM-5. So this happens when the mood symptoms are more severe. So the mood can be depressed, there can be loss of interest or pleasure in most activities. There are oftentimes changes in sleep quality, appetite, feelings of worthlessness, guilt, difficulty concentrating, and possibly suicidal ideation. Now, postpartum depression can begin at any time within the first year following delivery, and most, about 87%, occur within that first 4 months. These symptoms persist for much longer than baby blues. These symptoms last at least 2 weeks, but they can last several months or even longer if untreated. This significantly impairs daily functioning, and it can include comorbid anxiety, OCD symptoms, or even psychotic features, which is considered a clinical emergency and requires urgent intervention. Postpartum depression affects approximately 10 to 15% of mothers. So, what are some of the risk factors for developing postpartum depression? So, any personal history of a mood disorder or a family history of a mood disorder puts you at a higher risk of developing postpartum depression. Developing depression or anxiety during pregnancy, even for the first time. Any history of abuse, whether it's physical abuse, sexual abuse, or other kinds of abuse. Lack of support, be it social support, financial support, other kind of support, places the person at a higher risk. If the pregnancy was unwanted or undesired, or if there were complications that happened during the pregnancy or during the delivery, these all can be risk factors to be on the lookout for. So when we talk about the consequences of untreated postpartum depression, we will look at this from the standpoint of the mother, also the infant, and then the broader family systems. So, for the mother, untreated depression can lead to a more chronic course of depression. It can lead to impaired daily functioning, a decreased quality of life, difficulty bonding, difficulty breastfeeding, social and other relationship problems, and an increased risk of suicide. For the infant, it can lead to, again, impaired bonding, early cessation of breastfeeding, missing preventive healthcare visits, vaccinations, having a higher risk of behavioral problems, developmental delays, and attachment disorders down the line. And then for the broader family system, it can lead to increased stress in the family, increased conflict, emotional withdrawal from family members, and then disrupted family dynamics. So, we do need early screening and assessment to identify postpartum depression. So, what are the recommendations and timing for screening? Well, different organizations have put out guidelines that are all pretty consistent. So, ACOG, or the American College of Obstetricians and Gynecologists, and the United States Preventive Services Task Force, the American Academy of Pediatrics, and the American Academy of Family Medicine all have guidelines. So, ACOG's guidelines recommend screening at the initial prenatal visit and then again later in pregnancy, at least once in the second or third trimester, and then again in the postpartum period, with additional assessment if risk factors are present or if symptoms emerge between visits. And the American Academy of Pediatrics recommends screening at the 3, 9, and 12-month well child visits. So, overall timing during pregnancy, at least once in the second and third trimesters, at a postpartum obstetric visit, and then repeated screening at 6 or 12 months in OB and primary care settings, and at pediatric visits at 3, 9, and 12 months. So, there are multiple times that we interact with the mom where we can screen for postpartum depression. So, how do we screen? Well, there are multiple tools, but there are two that are well validated and used frequently: the EPDS and the PHQ-9. The Edinburgh Postnatal Depression Scale, EPDS, was specifically designed for perinatal populations. This scale omits some of the somatic symptoms that might overlap with normal postpartum experiences. It's a 10-item self report questionnaire that asks about symptoms during the past 7 days and addresses mood, anxiety, sleep, and self harm. The PHQ-9, or Patient Health Questionnaire 9, is a 9-item self-report questionnaire that's validated in both the general population and the perinatal population. This questionnaire asks about the past 2 weeks of symptoms as opposed to 1 week. It aligns with those DSM diagnostic criteria for depression, and this tool specifically asks about suicidal ideation. This one might be favored if it's already integrated into the electronic health record or clinic protocols, which it often is. These two tools have comparable sensitivity and specificity, and the overall diagnostic performance is similar. Any positive screen should prompt further evaluation for postpartum depression. Let's talk about bipolar disorder briefly. So, these screening tools don't distinguish between unipolar and bipolar depression. And we know that 1 in 5 positive depression screens might be bipolar depression. So, we can ask about these during the clinical interview, and we can add a mood disorder questionnaire, the MDQ, for those who have a positive depression screen. This is especially important before starting an antidepressant medication because misdiagnosing bipolar depression as unipolar depression can lead to inappropriate treatment with antidepressant monotherapy and even precipitate mania or a mixed episode. So, a comprehensive clinical assessment should then be performed for anyone who screens positive. So, you'll want to confirm the diagnosis of a major depressive episode with peripartum onset by identifying at least 5 symptoms that last at least 2 weeks in duration. And these include the symptoms that we already talked about, including depressed mood, loss of interest and pleasure, and has significant functional impairment for the day-to-day functioning. You want to evaluate how severe are the symptoms and then rule out any other psychiatric illness, including, again, Are they postpartum blues? Is there a postpartum psychosis present? Is there a bipolar disorder present? And again, just to repeat, it's urgently recommended that a psychiatric referral occurs if there is active suicidal ideation or any sign of psychosis. Before we start to discuss the treatment approaches, I'd just like for you to think about which of these patients might benefit most from rapid postpartum depression management. So let's talk about the general principles for treatment. So, individualized treatment plans should be based on the severity of the symptoms, the individual preferences of the patient, and breastfeeding status. These principles do include lifestyle interventions, as well as psychotherapy and a pharmacological approach when needed. It's ideal if there's a multidisciplinary care team that has coordinated care between the obstetrician, the psychiatrist, the pediatrician, the therapist, and any other healthcare professionals. Let's look at some lifestyle interventions that can be helpful. So, sleep. Sleep is a pillar of wellness. And we know that in the postpartum period, it is really difficult for women to get adequate sleep. So, supporting this in whatever way possible can be very helpful, whether that's enlisting the support of people in her life to help by taking care of the baby during the night, helping with diaper changes, overnight feedings, soothing the baby, anything that can help the woman get a good night's sleep. Nutrition. Nutrition is very important and also often overlooked. And so bringing food to the family after there's a new baby is pretty common. But then after time goes on, a lot of times the meals stop coming in. So making sure you're supporting the person and getting good nutrition, having healthy snacks on hand that they can use if needed can be really helpful. Any kind of movement or physical activity. So it's hard to kind of keep up with physical activity when you have a newborn at home, but encouraging her to get outside, get some sunshine, walk even for 10 or 15 minutes can be really helpful. Social support is critical, making sure that she has those social connections, that she doesn't lose touch with friends, and also for me time, time that she has to herself. Because for first time moms, they're often going from really a lot of independence to really not having much time to themselves. And for non first time moms, they probably didn't have a whole lot of independent time to begin with. So making sure that you're helping support some independent time is also really helpful. And then there are lots of stress reduction techniques you can use. So some of the common ones are mindfulness and meditation, yoga, grounding techniques. So some of these lifestyle interventions can be sufficient for helping with postpartum depression if it's of a more mild or moderate nature. Psychological treatments are first line treatments for mild to moderate postpartum depression. So these can include things like cognitive behavioral therapy that's going to address unhelpful thought patterns that can lead to more depression. Interpersonal psychotherapy that looks at any kind of role transition or interpersonal relationships. Peer support groups, very helpful, whether that's at a local level or online. Or we have also a phenomenal support group in Postpartum Support International. So you can often find these groups in a lot of places. And then mother infant interventions can really help with bonding and also helping the mother have more confidence in her parenting. So, let's talk about some pharmacologic treatments that can be used for more severe postpartum depression or when psychotherapy alone has been insufficient or is unavailable. So, one of the most studied pharmacologic approaches to treating postpartum depression is selective serotonin reuptake inhibitors, or SSRIs. Serotonin, or 5-hydroxytryptamine, is synthesized from the amino acid tryptophan in the serotonergic neurons, primarily located in the Raphe nuclei of the brainstem. These neurons project widely throughout the brain, influencing various functions, including mood, anxiety, and cognition. When serotonin is released into the synaptic cleft, it binds to serotonin receptors on the postsynaptic neuron, leading to a cascade of effects that regulates mood and emotional responses. However, the action of serotonin is tightly regulated by its reuptake into the presynaptic neuron. The reuptake of serotonin is primarily mediated by the serotonin transporter, or SERT. This transporter is responsible for clearing serotonin from the synaptic cleft, thereby terminating its action. In individuals with mood disorders, this reuptake process can lead to decreased serotonin levels, contributing to symptoms of depression and anxiety. SSRIs work by specifically inhibiting the SERT, increasing the concentration of serotonin in the synaptic cleft, activating serotonin receptors, particularly 5-HT1A and 5-HT2A, which balanced activation is crucial for optimal mood stabilization. Alternatively, patients with postpartum depression may be prescribed serotonin norepinephrine reuptake inhibitors, or SNRIs. Norepinephrine, or noradrenaline, is synthesized from dopamine in noradrenergic neurons, primarily located in the locus coeruleus of the brainstem. These neurons project widely throughout the brain, promoting wakefulness and arousal and facilitating sensory signal detection. Studies have also shown that it may influence some areas of cognition and behavior, such as attention, working memory, long-term mnemonic processing, and behavioral flexibility. When norepinephrine is released into the synaptic cleft, it binds to adrenergic receptors on the postsynaptic neuron, leading to various physiological effects, including increased alertness and improved mood. However, the action of norepinephrine is tightly regulated by its reuptake into the presynaptic neuron. The reuptake of norepinephrine is primarily mediated by the norepinephrine transporter, or NET. This transporter clears norepinephrine from the synaptic cleft, terminating its action. In individuals with mood disorders, this reuptake process can lead to decreased norepinephrine levels, contributing to symptoms of depression and anxiety. SNRIs work by inhibiting the reuptake of both serotonin and norepinephrine, leading to the activation of alpha and beta adrenergic receptors in addition to the serotonin receptors. Finally, the most recent approach to the management of postpartum depression involves the GABA system. The GABAergic neurotransmission and the use of neuroactive steroids acting as positive allosteric modulators of GABA A receptors. The complex interplay between excitatory glutamatergic neurons and inhibitory GABAergic neurons is essential to achieving balanced cortical neural activity. The glutamatergic GABAergic balance is tightly regulated by the biosynthesis, transport, and signaling of the respective neurotransmitters glutamate and GABA in the central nervous system. GABA is present primarily in local interneurons, but also in long projection neurons in the prefrontal cortex, anterior cingulate cortex, amygdala, nucleus accumbens, ventral tegmental area, and the hippocampus, the regions functionally associated with decision-making, cognition, intelligence, memory, sleep, emotions, motivation, and pleasure. The GABAergic deficit hypothesis proposes that depression may be the result of reduced levels of GABA in the plasma, cerebral cortex, and cerebrospinal fluid, altered expression and composition of GABA A receptors, and reduced levels of neuroactive steroids such as allopregnanolone in the CSF. The failure to upregulate GABA A receptors in response to the rapid drop in levels of allopregnanolone postpartum is likely involved in the development of postpartum depression. Studies have shown that SSRIs can normalize decreased levels of allopregnanolone in the CSF, and this change has been correlated with improvements in depressive symptoms. Neuroactive steroids bind the GABA A receptor at allosteric sites and increase the GABA A receptor current by increasing chloride conductance. GABA A receptors are ligand-gated anion channels, typically comprised of alpha and beta subunits, 2 of each, along with a single gamma subunit in synaptic receptors or a single delta subunit in extrasynaptic receptors. Zuranolone is an oral, synthetic, neuroactive steroid and pan-allosteric modulator of GABA A receptors that binds to the alpha-beta subunit interface. Zuranolone enhances both the synaptic and extrasynaptic GABAergic currents, leading to increased inhibitory GABAergic signaling. So, we need to think about how do we select the right treatment for the right patient. So, SSRIs are generally considered the first-line pharmacotherapy for postpartum depression. So, some considerations are that efficacy can take several weeks, about 2 to 6 weeks. There's also a side effect profile that is often well tolerated, but sometimes does lead to some side effects that are intolerable. It's really important to ensure that there's not an underlying bipolar disorder or history of mania, as we already mentioned. For SNRIs, these are also used rather frequently. They're often considered when the SSRIs have not been effective or if the SNRI has worked well for them in the past. There's really a similar time frame, that 2 to 6 weeks, and also the similar side effect profile as SSRIs, but it may be a little more difficult to stop taking SNRIs because of discontinuation effects. Zuranolone, as we mentioned, is an oral neurosteroid. It's taken daily for 14 days. This was approved in 2023 for postpartum depression, and it works very rapidly. You often see symptom improvement within days and by the end of that 14-day course. When we think about breastfeeding mothers, we want to talk about how the medication choice can impact breastfeeding. So, sertraline, escitalopram, and citalopram are often first choice for medication-naive individuals because they have favorable safety profiles and a really low infant plasma level and low risk of adverse effects in breastfed infants. Other SSRIs and SNRIs also may be considered first line, especially if the person has had a prior positive response to that medication. Mirtazapine and bupropion are more second-line options just because there's less data available, but we're getting more data all the time. And so even though these are generally reserved for times when other medications are not effective or not tolerated, we do sometimes use them to treat depression in people in whom these medications have been effective in the past. There are no known adverse events with mirtazapine at this point, but there are 2 case reports of infant seizures with bupropion. With zuranolone, there are no published clinical data on infant outcomes following exposure to zuranolone through breast milk. Zuranolone may be preferred when rapid symptom relief is imperative or when other treatments have not been effective or tolerated. So we really suggest a shared decision-making process with careful infant monitoring for sedation. Some guidance recommends pumping and discarding breast milk for 1 week post-treatment, since breast milk concentrations drop to undetectable levels within 4 to 6 days after the final dose. So, to review, when we're thinking about treatment options, zuranolone, SSRIs, and SNRIs, we want to think about the onset of effect, knowing that zuranolone tends to be fast and work within days. SSRIs are slower, around 2 to 6 weeks for maximum effect. The treatment duration for zuranolone is only 14 days, whereas with SSRIs and SNRIs, it's more ongoing. For breastfeeding, we really have insufficient data for zuranolone. For SSRIs and SNRIs, we have quite a bit of data that it is a safe option in breastfeeding. Sertraline is often the one that is used the most, but other medications are also used quite frequently. Thinking about cost and access, since zuranolone is a newer medication, it is more expensive and probably will need a pre-approval, whereas the SSRIs and SNRIs are inexpensive and very widely available and covered by most insurances. The mechanism for zuranolone is a GABA A modulator, whereas SSRIs and SNRIs work on serotonin or serotonin and norepinephrine reuptake. So, overall, big picture, with zuranolone, this might be best for very acute and severe postpartum depression symptoms in people who are SSRI intolerant, who have really severe insomnia because it acts on GABA and can really help with sleep, and also with agitation. SSRIs and SNRIs might be better for long-term mood stability because it's not a 14-day course, it's a longer course of treatment. So before we conclude our program, I'd like to prompt you, the audience, to pause the video for a minute and think about one or two patients you've seen today or this week in your practice. What's one way you could use your knowledge of these guidelines, screening tools, interventions, and treatment of postpartum depression to help them specifically? There are a few points that I'd like you to take away from this presentation. So if you are seeing postpartum patients, you are seeing patients with postpartum depression. And timely and effective treatment can significantly improve outcomes for both the mother and the child. Treatment should be individualized and include a multidisciplinary care team, offering a holistic approach including lifestyle interventions, psychotherapeutic interventions, as well as a pharmacological approach when needed. And treatment selection should be a shared decision and be based on patient-specific needs. Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.